Thank you, Amy. Thank you for presenting. We appreciate your willingness to share. We have one more, Dave McGraw, and I'm going to let him also introduce himself. Thank you for your willingness to speak. I know Dave is actually on vacation this week, much needed rest, so I especially appreciate your willingness to share this week. Thank you, Dave.
You're very welcome. Thank you for inviting me. I do like to, this is one of those things where Christy will have to probably just shut down the entire presentation because I tend to talk a long time. As Christy said, my name is Dave McGraw. I'm the Director of Emergency Preparedness and Response for Spanish Peaks Regional Health Center. We are in a unique position. If you would go ahead and advance the slide, Anna, that'd be great. Thank you. I'm not sure right now that I would add a lot of things that would be unique to our situation with the activities that everybody else has done, the visitor screening, limiting points of entry, very strict visitation guidance, the social distancing, testing, all of those things, pretty much everybody by now is doing. One of the unique things that I do have for our area is that I am a 20-bed critical access hospital along with a 120-bed veterans nursing home. So I get to play both hospital and long-term care. And that was one of the things that early on we didn't wrestle with, but we did make the decision that we're going to look at all the different guidance that's coming out for both hospitals and nursing homes, and we were going to follow whatever was the strictest. And realistically, nursing homes have a lot more restrictions than hospitals. Hospitals, by their very nature, are somewhat restricted. If you've got a disease outbreak, or even if it's just the flu, you're going to limit just naturally who goes into that room and who are the visitors and where did they come from, that sort of thing. So with the nursing homes, very, very open atmosphere where they have visitors any time of the day or night. So those were the kinds of things that we looked at, and we followed the strictest guidelines on that. The talk about the PPE has been very interesting, and thank you 3M for taking the time to be on and give us some updates on where you guys are standing in all of the efforts, because I know it's been very overwhelming for you as well. We had a large stockpile of PPE that we put in place in 2010, 2011 from the H1N1 breakout. And that came through a lot of the hospital preparedness grant funding that was available for hospitals at that time. And it was a stockpile that we're still actually using. So we were not disappointed at all when they came out and said, well, don't worry about expiration dates on the N95s, because I had 3,000 of them. And it's like, well, I'm not going to just throw those away. We're going to use them. So it was nice. We got permission as long as the bands and the seals were still good, which so far we have not had an issue with any of those older ones. So that's been a very, very big help. We set up one of the unique things that maybe we did. We were able to set up a trailer in our parking lot, a box trailer, and we called that our COVID trailer. So we were people that had questions. Do I need to be tested? What about this? They would come in, they would get a consultation inside that trailer versus walking into our emergency room or into our outpatient services. So we were pre-screening them, and obviously anybody that had severe symptoms was sent to the emergency room for treatment. But if it was just the worried well, we wanted to be able to talk to those people, give them some advice, whatever that would happen to be for their unique situation. And if they had the signs and symptoms, we would also do the testing out there versus them coming into our emergency room and potentially contaminating it. It was just a way we could still provide the treatment, but also keep the separation. Next slide, please. Some lessons that we learned early on, and I know this was true with every facility in the country, the amount of information was just almost completely overwhelming. A lot of sources, and sometimes that information was an interpretation of information, like coming from a consultant versus actually from the regulatory agencies, and even within regulatory agencies, there was some discrepancy and some differing views, and it was hard to determine what is a requirement and what is a recommendation. And we didn't do a good job with that early on, because every time something came out, we treated it as a requirement. And so we were oftentimes trying to make changes on changes 3 times a day. And it got to the point after the first week where it really culminated in it. And this goes into my second bullet there, is that we got a change that came down on a Sunday afternoon, late afternoon, ran up to the facility to make the change and implement it, and told the staff this is what they had to do, and then tried to show staff how they had to do it. And that's where we finally saw we're making a mistake here. And we needed to, yes, look at the change and say, is this a change that's a recommendation or a requirement? If it's a requirement, we're going to have to do it, but let's make sure we know how we're going to do it, how we're going to implement it, before we just go up and tell staff we have to do it. And then we also then said, okay, we're also going to then take a really deep breath. And because most of these changes were coming in the afternoons, we're going to take a deep breath and make sure that it's still the correct change the next day, unless it was something that was a critical life-threatening issue. But if it was a more of, a lot of the different things that we were seeing, we said, let's wait and make sure it's still applicable the next day, because we also found that there were many times things changed overnight. And therefore, when we were doing that, we slowed down, going up and telling staff 100 times a day that this is what we need to do. So it gave them a little more confidence that we were a little more in control. But the big thing that really pushed it as well was that change that came down on a Sunday afternoon, and we caused more problems as a response team, as the incident command team, trying to show staff what they needed to do instead of just let staff do their job. They are amazingly creative, and you tell them what needs to be done, and you guide them, you answer their questions, but you let them do it. We don't need to be doing it for them. And when I saw that, I grabbed the command team and I said, we need to get out of here, let them do it, and go downstairs. We need to make sure they're doing it according to the guidelines, yes, but let them figure it out, because they're going to, and we're just going to mess it up. And so that was a good lesson for us. Depend on your staff. You've got good staff. Use them. Let them be creative. And it gives them buy-in into the process, which helps them say, okay, now we're doing our part. One of the things I know we are starting the process of doing, and we'll continue to do, bullet point number 3 there, is the ordering of PPE on an ongoing basis before it's a crisis. Not depending on another outside resource, the strategic national stockpile, state and local caches, those got depleted within the first 2 weeks. And I'm in a rural area. I'm 40 miles from anywhere. We never have been a hotspot, thankfully. We're not wanting to be a hotspot, but they send the PPE first to hotspots. But yet the regulations for nursing homes apply to me just as they do anywhere else. And so it's hard to get the needed supplies. And if you don't have them, if I didn't have that hospital grant money stockpile that we had from 10 years ago, we'd have been hurting in the nursing home. It'd have been hard to follow those guidelines just because we weren't a hotspot. And so we weren't the first ones getting the supplies when they were coming. We got them eventually, but not right up front. So how much do you need to have? I don't know. 2 weeks, 4 months. It's going to be hard to determine that. And that's why you really do need to be looking at your burn rates and understanding what those mean and what is happening in the community, and start that process now. Even if it's, I'm going to order 10 masks a month or whatever from now until we need them. Go ahead and start doing that. We also found vendors were looking at our order history. And if we suddenly had ordered 50 masks a month, and now we're ordering 500 masks a month, they were just throwing our order out. So they're saying, no, we're not going to give you more than what you used to order. So that is something that you really need to be doing now. Start establishing those now, and especially for long-term care facilities, because that's not something they really were looking at, I don't think, big picture, how it was going to affect them like this did. Next slide, please. And can these lessons be translated? I really do believe that they can. Short answer is yes. They absolutely can be transferred to other types of facilities. You know, we all plan for that sudden, short-lived, that 1 day, 2 hour to 2 week event. And we've done that, and we're getting really, really good at that as healthcare facilities and healthcare coalitions. We're really good at that. Well, now we have a real life example of something that's lasted a whole lot longer than probably any of us thought that it would. And so that's something that we need to make sure we're taking those lessons learned. And I agree with the presenters that have already done their initial during action reports, and that they're already making improvement plans for what they've already learned. We're doing the same thing. We shut our incident command down just a few weeks ago, and so we're putting together these lessons learned that we've gotten so far, so we can start working on those now. And having that real event also gives us the opportunity to say what really did work, not what do we think will work, but this really did. And so it gives us that better understanding. You know, depending on the government stockpiles, that's a wonderful concept, but it's also cumbersome and it's elusive for rural communities. And it takes them time. You know, they're not sitting there waiting for the bad thing to happen. They're waiting for us to say, hey, it's a bad day. We need your help because we've depleted our local resources. And so it takes them time, and we have to be better prepared, just the plain and simple, to take care of ourselves and be ready for those days and not be dependent on the government to get us through those first few weeks or even months. So that's where we're at as a facility right now with our response.
Thank you for sharing, Dave. I have some questions for you from the audience. Let's see, did the planning you did for the CMS emergency rule help you be better prepared for COVID-19?
The answer
And
is
then, oh, yeah,
okay.
okay. Oh, there's another question too that I lost. Dave, did you pull in your EMS and ambulance providers into your plan? If so, how? So both of those questions I'll let you answer.
Okay, I'll start with the first one. Definitely, what I will say is the CMS rule, when it went into effect, it really made us focus on some areas maybe we hadn't been. With the nursing homes, long-term care facilities nationwide, I think we're probably behind the 8 ball when it came to CMS. The one advantage that I had was being tied into the hospital already. A lot of what the CMS rule came out with, hospitals were doing to a great extent already. And so it was more of an enhancement of their programs. And in running this program for our facility, which I hadn't mentioned, but I've been doing it for 29 years at the same facility. Whether that's a good thing or not, I'll let somebody else decide that. But we have always tried to run our facilities as one. So whatever we did for the hospital, we were doing in the nursing home as well. So our nursing home was ahead. You know, our emergency preparedness committee, we had that committee that involved both long-term care and the hospital. We already involved the community. Our county emergency manager is part of our emergency preparedness committee. We had a lot of consulting work that we did through our hospital association, which again, we tied it with the nursing home at that point. We got our continuity of operations plan done before it was the popular thing to do. And we had some help with that. And again, we pulled the nursing home into the hospital side of it. So getting that all together, CMS helped enforce that. It kind of gave me the the carrot to dangle out in front of our administration and say, okay, now it's a rule. And I had great support before that. I don't want to say I didn't have that support, but I did have it. But it is something now that has to be a focus, because now it is something that is looked at very, very closely. And what was the second question again? I talked too long.
You're fine. Um, it was, did you pull in your EMS and ambulance providers into your plan? And if so, how did you do that?
We absolutely did. About a year and a half ago, we actually took over the county ambulance and EMS service here in Walsenburg. So they were already part of our facility, and then bringing them in, there was a lot of back and forth. We had to work with dispatch as well and gave them a list of questions so that when they got somebody that called in and needed an ambulance and said, hey, I've got shortness of breath, I've got a fever, the dispatch would pre-screen by asking certain questions so that our EMS staff knew what they were going into. We also made sure that they had been fit tested or had PAPRs for respiratory protection, and all the PPE they needed was all on board. We also used them to help in the ER. If there is a surge event or something, we didn't really let them go into the COVID area treatment rooms or screen out rooms, but they knew and understand what the other protocol was, which then freed up staff to help do that. So our EMS staff is definitely an integral part of our facility, not just for COVID though, but we do that on a day-to-day basis with them as well.
Excellent. Thank you so much for sharing your lessons learned, Dave. I appreciate that.